Hi, everyone. Welcome to today's webinar on building community resilience, addressing the pair of ACEs and preventing child maltreatment through a cross-sector approach. I'm Sarah Brandspiegel. I'm an instructor at the Colorado School of Public Health, and I work with the Program for Injury Prevention, Education, and Research. We facilitate the National Peer Learning Team on Child Maltreatment Prevention, which is a national network of people working in public health and social services who come together to learn about primary prevention approaches to child maltreatment. Our NPLT is funded by the Centers for Disease Control and Prevention, and it's a partnership between the Colorado School of Public Health and the Colorado Department of Public Health and Environment. So thanks so much for being here today. I'm excited for this second in our series of research in progress webinars on preventing ACEs and child maltreatment. We're using Zoom today for the webinar, which probably most of you are familiar with by now, but just a few quick housekeeping notes. Please use the Q&A feature to ask any questions. We'll have time after the presentations to go through those questions, so we encourage you to share your questions as they come up for you. Also, we are recording the session, and the link will be sent out after with the slides and also posted on our website. I wanted to draw your attention to some upcoming webinars in this series. June 17th, we have a session on evaluating organizational policies to prevent child sexual abuse. And July 14th, promoting economic stability to reduce child maltreatment through a policy approach. So I encourage you to sign up for those if those are of interest to you and your work as well. I want to take a moment before I introduce our presenters to just get a sense of who's joining us today. So I'm going to open up a poll here. Please tell us what sector you work in. I know we often have folks from public health, social services, education, nonprofits, but just take a moment and complete the poll, and we'll take a look at who's here today. Great. You see results coming in. I'll just give it a few more moments to please vote or answer the poll if you haven't yet. Okay, great. So let me share these results. So looks like 35% of our attendees today are coming from the public health sector and 33% from the nonprofit sector or community-based organizations. And then also substantial amounts from social services and other sectors. So that's great, and it's great to see a mix of sectors here, especially because our presenters will be specifically talking about cross-sector approaches to prevention. So now I'd like to introduce our speakers today. They'll be talking about research from the Redstone Global Center for Prevention and Wellness. It's the academic home of a project focused on addressing childhood and community adversity as the root causes of many chronic diseases such as obesity, heart disease, and diabetes. And in 4 years, the Building Community Resilience Networks and Collaborative has grown into an internationally recognized public health movement, working to prevent and mitigate what Wendy Ellis has coined the pair of ACEs, adverse childhood experiences within the context of adverse community environments. Our speakers today will be providing an overview of this initiative and their research findings. So first I'll introduce Mr. Jeff Hild. He's Policy Director at the Sumner M. Redstone Global Center for Prevention and Wellness at the Milken Institute School of Public Health. And in this role, Jeff works with local, national, and global partners to develop, promote, and advance policies to prevent and treat obesity and build healthy and resilient communities. And you can read a little more about Jeff's background here. And I will also introduce Mr. Harrison Newton. He is Deputy Director at the Center for Community Resilience and most recently served as the first Deputy Chief Resilience Officer in the nation's capital, co-leading a cross-sector citywide effort that culminated in the city's first resilience strategy. In that role, he coordinated 5 resilience-focused research teams spanning Washington, D.C.'s health, housing, economy, technology, and emergency management agencies. So we're very happy to have you both here. And I want to again remind attendees to please put any questions into the Q&A box. We are recording this session today, and so you can access the slides in the recording after the session. And I'm going to turn it over to Jeff and Harrison now to pull up their slides and begin sharing.
Hi, good afternoon, everyone. This is Harrison Newton. I am Deputy Director for the Center of Community Resilience at George Washington University in the Milken School of Public Health. I hope everyone can hear me. I'm really interested in your organization, your network, and I'm really just glad to be here with you today. Um, so I will begin really just by telling you a little bit about who we are, what we do, why, and how. So here is, again, us. I'm Harrison. Jeff is also on the line and will be taking the reins to talk about our policy efforts. Also, not pictured here, but on with us today is Daniel Chen, our Director of Research, who is really been pushing the envelope in terms of deploying new data methods and approaches to supporting communities as they pursue resilience. So getting underway here, if you know anything about our organization, within a few seconds you'll have seen many versions of a tree, and we'll talk a little bit about how we discuss resilience, which is, I know, a word that is used in many contexts. As was said, I actually, prior to working as deputy director here at GW, I was the deputy chief resilience officer in Washington, D.C. And I essentially worked in the mayor's office to create, craft, and lead an effort to design a resilient strategy for the district. It certainly had public health ties. One of the chapters was Safe and Healthy Washingtonians and dealt with mental health and trauma. One of the overarching themes and or lenses was equity. Equity and governance, actually, we labeled it. So my background in this area is a little bit varied, and I certainly, like you, I'm sure I've heard the word resilience used in quite a few contexts, and sometimes in situations in which it's framed differently. I definitely want to talk about how we frame the word resilience and the deep tie to public health. So here you see 4 different trees. One is labeled the Center for Community Resilience on your far right. What we believe we are doing is catalyzing a resilience movement. Um, to the left of that, you'll see building community resilience. I'll talk a little bit about that. Building community resilience is essentially a national network of local coalitions and actors working really as a kind of a national learning collaborative that's based on a framework and model that embeds what we call the pair of ACEs, adverse childhood experiences in their surrounding environments, adverse community environments. So there's a network of actors that really come together to share learnings and to set course for change in their local context. And I'll talk about who's a part of that network and what we do with the network. Below that, you'll see the Policy Lab. My colleague Jeff, the policy director at Redstone, will discuss a lot of our work that relates directly to that effort. And then finally, to the right, we have Resilience Catalyst, Public Health 3.0. Resilience Catalyst is a project, a partnership between CDC, NACCHO, APHA, and ourselves. And that project actually is a very, I think you'll find it very interesting in that it certainly even has a pure tie to public health, as it has us working with local health departments across the country as pillars of resilience in their local areas. So I'll be happy to discuss that as well. So here you see why we have a tree as our logo. It's because really we were among the first, if not the very first, to adopt this model for discussing the pair of ACEs, the adverse childhood experiences and the adverse community environments. Uh, Really what we're trying to do is focus everyone on systems driven adversity, um, taking people from the population health and community outcomes that you see uh, on top of the ground, and really helping people to see what's underneath the ground, what's in the soil, as we like to say, policies and systems. And of course, when we begin to talk about when we move from outcomes to systems, then we kind of go from a place of thinking about trauma, equity, and ultimately resilience. That equity piece is important because if we're talking about policies and systems, it's impossible to do so without understanding the history of those policies and systems. And as soon as you do that, you're going to, begin a conversation that intersects race and discrimination and institutional racism and all sorts of other things that are tied to the last the entire history of the country, but certainly the last 50 years. The policy impacts obviously are still here with us today. So our network building community resilience actually began in 5 different communities that you can see here. Oregon, where we were primarily working focused on mental health. Trillium Family Services in Oregon is I believe the state's largest provider of mental health services. In Missouri and Kansas, we have the Alive and Well communities, a strong coalition of public health focused partners. Cincinnati, Ohio, we have Cincinnati Children's and joining forces for children. Uh, Again, strong public health focused actors. In Texas, we have the city of Dallas, where also I think our coalition actually was a huge part of the work that was occurring there in developing a resilience strategy. One of my colleagues in Dallas, a resilience officer, almost in the same time frame that we were in Washington D.C. creating a resilience strategy, they too in Dallas were doing the same. And then finally in Washington D.C., the office that I formerly worked with, Resilient Washington D.C., the mayor's office, others in the district, particularly actors who work in underserved communities. Um, so that have come together to form a local coalition that we are a part of and support. So that's what building community resilience looked like, closer to its inception. And here you can see what it looks like today. We have many more partners that work with us. Most of these partners that you see, actually all of the partners that you see here, work with us in the context of what we call the Building Community Resilience Network, or that Resilience Catalyst project with CDC and NACCHO that I mentioned, where we're working directly with health departments. All of these sites are going to be one of those two approaches. And you can see we've grown in a pretty short period of time. We're just now 5 years old. I understand that a lot of you are from all over the country, so I'm going to assume that some of you are actually, if not in these communities, nearby them. So I'll certainly be interested to hear later if your work intersects any of the organizations that you can see here. So how do we do what we do? And even more of what we do. So we actually have a model, community resilience framework, that really begins with what people have called, or what we've called in literature, the social determinants of health. and interprets them as system drivers in health as a way to focus coalitions and policymakers and communities on really trying to think beyond the issue of the day or the outcome of the day, but to think about the systems that are at work. And to do that, we essentially are working with local coalitions in the process that you see before you. We are working on things like shared understanding, which has a lot to do with um, working with community, convening in community, bringing together cross-sector partners to discuss issues and themes. Um, we certainly approach the state of readiness, which is really about understanding provider capacity and system capacity. What are the policy supports that are at play? Uh, we, of course, are going to be pulling in cross-sector partners and thinking about how they connect, how they can collaborate, how they can share resources, and what are the partnerships that are going to be necessary for change. And then finally, community. We're looking at citizen leadership, attachment to place, organizational linkages, so on and so forth. And the reason why, of course, it looks like a circle without end is that all of these things continue to, are always upgrading. We've never finished community engagement. We've never finished building shared understanding when we're working with communities. And so as we interact with our community partners and support them in this work, and I think you'll get a clear picture of exactly what we're doing with communities. I want to point out that the tree that frames how we even approach these topics is very relevant in our current COVID-19 context. It's, I think, very easy and obvious to understand that with COVID-19, those outcomes that we are concerned about are exacerbated, and new poor outcomes are even in evidence. And so there's even a greater need to think about what are the drivers, what are the systems. We can come up with mitigation efforts in the short term, but we know that 6 months, 9 months, 2 years out from now, we will still be experiencing the effects of COVID-19 on our populations, and we will absolutely, therefore, have to think about uh, how are we going to alter systems? How are we going to improve systems? It won't be enough simply to think about things in the context of reopening or going back to the way things were. So when we talk about shared understanding and we do that in a frame of thinking about systems, the first thing that happens is communities have to engage and want to engage, generally speaking, in conversations about the past and policies of the past. Here you can see a list of different policies, and I think none of them will be, new for any of you on the phone. We often start with redlining right there in the center because it's the policy action that most people are familiar with. Even lay people are generally familiar with the idea of redlining. It's also the one policy or concept that people cannot deny. It's as clear as it is possible to be in terms of these were policies that absolutely had an inequitable effect on by design on people of color. And so, that is oftentimes where the conversation starts, but it's not where it ends. And this conversation isn't just one of federal policies, but we find that in localities there are, all of these different policies were experienced in different ways. What redlining meant in Baltimore, which neighborhoods were impacted most, and what chain reaction was set off because of redlining looks differently depending on what community you're in. Even if you think about environmental health and you think about the placement of uh, you know, pollution sources, or where highways were constructed, or even where waste facilities were placed near particular communities. All of that will be unique to each community. Each community will have its own story, and that story will certainly be connected to the outcomes that community actors are hoping to mitigate. And so when we talk about shared understanding, we're often talking about not just policies at the federal level. We do definitely talk about those, but certainly then how did those things play out uniquely in your city or community? So when we think about the impact of systemic inequity, we look at what's happening actually in communities. Again, I don't think any of this is that surprising, but we can see clearly how there's a link between a lack of economic mobility that puts essential workers at disproportionate contact risk as it relates to COVID-19. But even this reality of low lack of economic mobility, putting at greater risk, people, generally people of color, people of lower income. Uh, it's always putting those people at a greater health risk. Today, it happens to be focused. We happen to be focused on COVID-19, of course, but that dynamic exists all the time. So as we work with communities, we provide them tools and strategies for building and designing coalitions or strengthening coalitions to do the work. We create a large number of tools around that. Here's one, our newest, it's a toolkit on equity that seeks to help communities and coalitions understand how to connect the parabases with equity and with a through line to community engagement and policy work. To give some idea of what that can look like, on the far left, you can see one of our infographic from that toolkit, where we've really tried to contextualize how policies and programs impact outcomes that we seek. And when we work with communities to create unique versions of our graphic documents, these are tools they can use in policy work. They're tools that they can use to build understanding. They're tools that they can convene around, discuss around, plan around. They really, we're really able to provide a large number of ways for communities and coalitions to take a data of this framework, apply their own local data to it, and then communicate, convene, and ultimately, focus on change. Oh, and to the right, so you can see what we're really doing here is visualizing community resilience factors, right? We're looking at the percentage of children with a medical home, percentage of families with consistent access to good and nutritious food, steady job growth, so on and so forth. We're finding what is the community context that is around the outcomes that you're concerned about. And then we're thinking about the soil. Here is a document, a tool designed for Florida, and you can see that it's focusing on the 25% of children who live in economically unstable households as a way to, again, provide context of the adverse childhood experiences. And then beneath the soil, you can see adverse community environments, the larger, more systemic issues. And I think that, as I said, we would talk a little bit about our frame for resilience. You're probably getting a sense now that a key to how we approach resilience is the concept that it really is more than just bouncing back, which some people think of resilience in the context of a system receives a shock of some sort and we need it to bounce back. We need it to come online again. We need it to reopen. And really, I think the public health, even the determinants of health, social determinants of health, and certainly those who are resilience practitioners take a broader view of resilience, really thinking about it as a set of characteristics that a system can have or not have. A system of communities can or cannot have. And so when we look at the what's in the soil, the adverse community environments, we can see that there's not resilience because these are conditions and these are contexts that will mean that the system is operating in a way that it will drive further adversity. So there are people who within the system will never escape that system of adversity, and that by and large means it won't be a resilient system. We know what happens because we're experiencing that at this very moment with COVID-19. One of the situations that I think first arose that made people more aware of the role of context in a moment like this is when New York was thinking about the need to shutter schools and realized that it would be quite a problem to shutter schools when many children, that's the only way they're able to eat during the day. So you have a context there of economic distress, and then you have a shock, and you're going to have a situation that's, it's not resilient by definition. So we've also been working to support communities with documents like you see here. Really, this is starting to tread, I think, on the ground that Jeff's going to cover. We have on the left a document that's focused on the greater Cincinnati area and giving some context to what is happening in this current COVID-19 moment. So the goal is to elevate community voices and the top adversities emerging for families during COVID-19 and articulate how community resilience and equity can be built for long-term change. And so this is kind of an infographic approach. This one's mostly text, but certainly we're looking at designing them that are more about data, quantitative data. But one of the things that I think that we often say in our work is no data without stories and no stories without data. We never want to see just qualitative data that has no quantitative, and certainly the opposite is true as well. One of the things we also experience in this COVID-19 moment is how how important data is, but how also important it is to have knowledge of community in which to give context to that understanding of data. I think one of the journeys that most communities have been on is that the initial look at where they were seeing the most burden from COVID-19 has evolved based on healthcare access, how testing was being deployed, and who could access testing. In Washington, D.C., at first, the first statistics that were being relayed indicated that actually it was not our most vulnerable and lowest income communities that were being most impacted. That was a kind of an eyebrow raiser for many and a shock to many, but over time it became understood that was really more of an outcome. The data was an outcome of disparity in accessing healthcare that could diagnose the test or diagnose the illness with a test. So telling those stories is very important, and helping our coalitions to tell those stories and push for change is really what we do and how we intersect the work. The last slide I'll share before handing to Jeff is a look at a data tool that we're beginning to develop. Really, we have developed, but we're beginning to deploy it in the context of the Resilience Catalyst in Public Health project. That project is really working foremost with health departments to convene around an issue that they select. NACCHO and CDC came into this project with the idea that there needed to be a larger resilience-focused discussion that really married our understanding of the connections between suicide, opioid use, and yeah, suicide, opioid use. Daniel, the third?
ACEs.
Thank you. ACEs. Right. And so I wanted to point this out because when we go on that journey with health departments, we're largely having a conversation about, if we take those three different areas, where do those intersect your community in a way that perhaps would be unique and necessary for the health department to be involved. So for an example, in Louisville, where we are deploying this project, the local health department chose eviction, which couldn't be more applicable to our current context either, right? Evictions have a very significant impact on health and health outcomes. And we attempt in our work with under the Resilience Catalyst Project to help everyone who's involved, the health department, coalition actors, stakeholders, other government agencies, to better understand how evictions are connected to health. How are those two, how are outcomes linked to drivers in the system that is eviction? And we use this tool that you can see in a very basic form, a dynamic systems model, to really promote a conversation about uh, how drivers impact outcomes, and which drivers are connected to which outcomes, and how, either negative or positive. And so you can see a very simple issue modeled in front of you. But doing this kind of approach with um, communities together collectively in one space allows us really to challenge each other and grow in our understanding, uh, to have real deep conversations about the connections. And once a model is created, there are all sorts of applications for then how it can be used. Certainly, we can apply data to that model and actually see how changing, let's say, educational attainment on the model in front of you, if it were to increase, what could we expect to be the outcome on unemployment? What does the data suggest now about the connection between those things? How should we decide as a coalition or a community of actors which thing we're going to try to impact? In a world of limited time and a number of different things we could all try to do, which is going to be the most important thing to impact to have the outcome we want on the issue at hand? So this is a tool that we're deploying, a data approach we're deploying currently as a part of the Resilience Catalyst project. Really, I want to again give attention to our research director, Daniel Chen, who's on the line, and he'll be able to answer any number of questions you have about it and describe it in further detail. But I'll leave that closer to the wrap up. So now, if I could, I'd like to turn it over to Jeff Hild, our policy director, to describe our policy efforts and to go even deeper into how we're using data in our work.
Thanks, Harrison, and good morning, good afternoon, everyone. Really lovely to be here with you. So I'm going to do two things. First, talk about how we're collecting and analyzing data to further the evidence base for this work, and also measure progress across our networks and within them. And then talk a bit about our policy work and how we're thinking about building a policy agenda to really sustain this work. And also hat tip to our research director, Daniel, who is on the call, who is really the guru of the data here. We developed our own tools, or what we call the data dashboard, to assess the progress at our local networks. And we created two modules, which you can see here. First is the network module that collects data regarding the level of cross-sector engagement and coordination. And second is a program module that collects program level data that measures the impact of being part of the collaborative maybe having on individual program outcomes. And so we collect and analyze both quantitative and qualitative data, and that collection occurs annually with each of the sites. And there are 6 domains of the survey modules: equity as a guiding principle, translating the pair of ACEs science into service delivery, systems coordination and integration, community engagement and leadership, use of data to inform practice, and financial sustainability. And we analyze the data to measure success, but also for identifying opportunities for growth. So for example, under the systems sector coordination domain, multiple sites had identified the need to partner with public health agencies as a key goal, but lacked the tools to do so. And that led us to a partnership with NACCHO to help facilitate that work. And then sharing across the network has also resulted in organizations adopting best practices from other entities. So for example, a lot of organizations were already collecting ACE data for people they served, but did not measure strengths of those service populations. So after learning about examples from other BCR partners, many entities changed their approach to begin thinking about their work as increasing strengths and buffers, not just on minimizing ACEs. So we can go to the next slide, Harrison. So here's a timeline showing the development of our measures and evaluation. So we developed the initial version of the network module survey after conducting a literature scan and not finding a suitable tool for measuring success. So for example, there's lots of surveys measuring coalition strength, but we couldn't find a tool that looks specifically at how ACEs can be addressed. There are a number of equity surveys, but we found them lacking in specifics about strategy and particularly around community engagement. So the initial survey was reviewed by each BCR team for content validation. And this iterative process really helped to shape the survey and ensure that we were measuring, that what we were measuring would provide useful feedback to the teams, and that the data already or could exist. So in other words, there was no additional primary data collection needed from the teams. So the preliminary analysis results were reported back to teams for feedback and identifying opportunity for growth. And again, that led to this NACCHO collaboration. The program module was developed in 2017 with additional content validation from the teams. And then a second round of validation was conducted in 2018. Because of the growth of the project, the teams have become much more diverse. We needed to make sure questions remained relevant and that wording was inclusive of multiple sectors. And second, some of the questions yielded consistent responses in the first two rounds, and so we now formatted them in a kind of a multiple choice presentation. And third, to improve the flow of the surveys. The next slide. Harrison, can you advance this slide for me? Right, so here's an example, an early example from the first two rounds of data collection in the network module. And this is really intended to kind of show you the format versus diving deeply into the actual substance of the reported information, particularly because this is from the initial 2 years. We've had subsequent rounds of data collection. So let's move to the next slide. So there are a number of challenges that our teams have identified at the network level, a number of which you can see on the slide there, and probably not many of these will be surprising to some of you who are doing similar type of work. But over the 4+ and I guess 5 years now of the project, we've seen some clear positive trends as well at the network level. So there's been a growth in each of the network's ability to educate and raise awareness around trauma, ACEs, equity, and resilience. And we've seen that these network teams often are a peer resource in their community. We've seen that challenges related to community engagement are certainly persistent, but that through better leveraging existing data, working to align priorities, particularly in regards to policy change, with things that are measuring already, and working to make data actionable for partners in our network is really helping their efforts to both measure engagement and communicate about their work. Next slide. So moving on to the program module. So this just gives you a snapshot of what that module looks like in the data dashboard. This is looking at just the initial round of collection from the Oregon cohort. You'll notice the equity question in the upper right corner. And if we move to the next slide, I'll talk a little bit more deeply about that. So as an example of how we collect and analyze data under the equity domain, and as you heard Harrison mention, we really ground our work in equity and undoing those system level drivers of inequity, and have really centered this both for our direct service providers in each of our sites, as well as for our non-direct service partners. So the equity measurement really starts with a quantitative yes or no question. Has your organization adopted an equity statement into your goals or mission? So we then examine those equity statements and track them over time. Then that's followed with another qualitative question regarding how being a part of a local and or national collaborative and learning community supports their equity work. We also look at demographic data, such as examining program participants versus program staff versus local community, to really look at the extent to which programs being offered, and the people offering them, as well as the people served by them, reflect the makeup of the community and whether this aligns with their equity goals and strategies. So an example of what this looks like in practice, during initial data collection at one of our sites, only 1 of 5 organizations included equity as a guiding principle, but had no attendant strategy or activity. By the last round, all of those organizations included equity in their mission, and 4 of them had specific activities and programs to advance that strategy. So looking at some of the trends under this domain, we find a steady growth from incorporating equity into mission statements to developing specific activities to support that goal. So one team went from marketing their trauma trainings to organizational leaders to instead target community members. Another set up a family advisory council to inform their programmatic decisions, and another explicitly changed their HR practices to focus on recruiting employees from the communities they served. Let's go to the next slide. So here's another example of just measuring cross-sector work within the program module. And this really maps out sectors for each project and seeks to quantify the number of families or individuals who are touched. And the piece that's not included here is really the depth of that touch or impact, which really gets to some of the qualitative questions and follow-up we do. So you'll notice that Keep Oregon Well, for instance, has a really broad scope, but the touches are light, mostly through media, versus something like the Integrated Behavioral Health Program, which obviously has a much deeper impact with folks who are served. So the next slide, please. So some of the key lessons we've learned in regards to data, about 5 years in. So our sites are both diverse internally and from one another. So a fixed tool would have seriously impacted our ability to use data to help identify challenges and opportunities for growth. So one of the key lessons was using an iterative and collective process to identify those domains. And in some respects, that process of measurement and evaluation had to track and account for some of the inherent messiness and evolution of cross-sector collaboratives. It has also been key to look at measures at both the network and the organizational or program level. This has allowed us to glean larger trends and opportunities while also supporting the growth and work of individual organizations. So the use of both quantitative and qualitative data has been critical. Some of the collection is now done over the phone or in person, and those sessions have often become strategic planning or learning opportunities to share examples from across the network. It's also been important to measure both process and outcomes related to our team's work around trauma and equity, and create a real feedback loop, both from us to each of the sites as well as across the sites. And having tangible process and outcomes measures for each has allowed us to do that work. So next slide, please. So we're going to move into some of our policy and advocacy work. So next slide. So our teams have really been focused on what we call the three Ps, so practice, programmatic, and policy transformation. And here is that tree again. And because of this framing, policy was really identified early on as the key to addressing the pair of ACEs and getting at changing those underlying systems-driven adversities, or the question we ask in communities is what is in your soil? And really changing those dynamics really becomes a policy question and a policy focus. So kind of two big focus areas or questions that are guiding us. So first is, how do we take the programmatic and practice transformations from our sites and translate those into policy recommendations at the institutional, local, state, and federal levels? And because we are based in DC, we do tend to have a strong federal focus, as well as the state and local work that our teams are doing. And then secondly, how can we support the teams in their advocacy and policy work through combining community voice and wisdom with data in ways that they can tell a really compelling story and to policymakers? And one of our favorite sayings is no stories without data, and no data without stories. Next slide, please. So in terms of supporting effective policy and advocacy work, I wanted to share just kind of this example from our Missouri team, the Alive and Well folks. And so their focus has really been on how to elevate the power of community members and have community lead in the policy space. And you can kind of see on the slide how they've worked through that. And they do a lot of this through a network of community ambassadors who help to both drive organizational priorities in the policy space, as well as serve as key links with the larger community. And they're also, part of the work we do is to train and support them to do advocacy work. And so we really view our role as building their capacity to engage in the policy realm through trainings, through the use of BCR tools, which we'll show you in a bit, that support them in identifying policy opportunities and really using data to effectively communicate their message. Next slide. So as the policy work has unfolded, particularly at the state and local level, we've learned some key substantive lessons about what is needed to prevent and mitigate the pair of ACEs and build truly equitable communities. So first is the focus has to be on working on addressing the underlying community conditions that drive adversity. What we found is there's plenty of work being done to kind of treat the symptoms of adversity, and where we see our teams having a unique role is getting at those underlying drivers. Second, we've learned that if you've seen one community, you've seen one community, and particularly that the experience of trauma in each community is unique, and so that guides us towards looking for solutions that match that particular community context. Third, universal approaches by themselves will not lead to equity, and so many of our sites have focused instead on what folks may know as targeted universalism of programs and service delivery. Fourth, the importance of backbone entities as essential to this cross-sectoral work, and also seeing that those entities often lack support to do that kind of community quarterback role. And so what are the resources that can be brought to bear to support that work? Financial incentives, creating financial incentives and eliminating barriers to create clinical and community linkages. And often those take place, in the kind of big P policy space, but more often than not exist as barriers kind of within institutions and within their own institutional policies. And finally, we've learned the importance of building the infrastructure for coordination and making sure that organizational policies as well as public policies can support this cross-sectoral work. Next slide. So I just wanted to give you a sense of some of the federal funding streams that have supported our partners um, in different work. So you'll see a number of these exist within HHS at SAMHSA, the National Child Traumatic Stress Network. Apologies for all of the acronyms, but just you can take the bureaucrat out of the bureaucracy, I guess, but not the bureaucracy out of the bureaucrat. Anyway, too much time in federal government, I think. Project Aware, so advancing wellness and resiliency in education. Also recast grants, resiliency in communities after stress and trauma, and a few others on that list. Reentry and community linkages through the Office of Minority Health, a number of ACF programs, and the one that you all are probably familiar with are the regional partnership grants out of the Children's Bureau, DOJ, Safe and Thriving Communities, and the Court Improvement Program have been utilized by some of our sites to do trauma-informed trainings within the justice system, for example. Department of Education, Student Support and Academic Enrichment Grants. So these are all kind of current federal programs that are helping to support this work. Next slide, please. So in addition to kind of working here in DC to increase appropriations for some of those funding streams, that we've had a proactive federal agenda as well that's grown out of this work. And I'll just highlight a couple things on this list. So one were some provisions in the Support Act. So that was the opioid bill from late 2018. Part of what that did was set up a child trauma interagency task force based out of HHS that was directed to come up with a set of best practices and also look at funding flexibilities within existing grant funding streams to better address ACEs and child trauma in community. And that work of that task force is ongoing. Also created a funding stream for grants to local education agencies to address trauma and ACEs in educational settings. That was authorized in the Support Act, and folks have still been working on appropriations there. I'd also point you towards some work we're trying to do in supporting innovation and building the evidence base for this type of ACEs related work. So we've been working with partners in Congress to better fund and support public health departments to do system dynamics modeling work, really with an eye towards ACEs. So that legislation is hopefully forthcoming. And then the Rise from Trauma Act, this is a bipartisan bicameral bill. And one of the things that it focuses on is money for local coalitions who are doing ACEs related work. So we see that as really important going forward to support and sustain the work that's happening at the local level. And next slide. I think I'm just about done. Yeah, so this is sort of our motto, the policy work of using collective impact models to do the work locally, but also engaging in collective advocacy to move the policy ball forward. Next slide. So we can advance the slide, Harrison, if you can. Harrison, can we move the slide forward? Maybe perhaps you're not hearing me. Yeah, so a bunch of our tools, including a policy and advocacy guide, the equity module Harrison mentioned, tools around coalition building and communications, lots of fillable trees to use local data to kind of paint the pair of ACEs picture, and conversely to use the tree as a picture of resilience and strength as well. So I think I'll stop there. So Harrison, I'm going back to you.
Hi. Yeah, I think now it's time for questions, if there are questions that folks had.
Yeah, let's go to questions. This is Sarah again. I have a few questions in the Q&A box, but I want to start by just thanking you so much for a great presentation. And I think it's a really powerful model to look at the context as we think about ACEs. I'd love to kick us off while people are thinking of other questions. We have about 5 minutes to take your questions. With a question that we got one from Washington State, asking about how do you connect if there is an initiative in your state, how do you suggest people connect with partners, and if there isn't an initiative like this in your area, are there tools? I mean, you mentioned a few tools here, but what would you tell someone who's interested in getting started?
Well, yeah, thank you for that question. I mean, I can take a crack at it. I think we are more than happy to connect you to the coalition that we're working with, or coalitions actually that we're working with in Washington State. Our relationship with Washington State is actually pretty complicated in that we have, I think, really four different organization, or I should say, organizational centers that we work with. One, a fascinating piece of work that we're doing is with the Tatawa tribe in Yakima County, where really the outcomes related to maternal and child health are quite desperate. And so, we're working to support the fantastic leadership of that tribe in kind of reclaiming the space around birthing, and uh, entering into kind of our the common context, how the tribal culture can achieve the ends that it desires when inequities are reduced. So that work is very fascinating. I'd be happy to connect anyone to it. In terms of how can you make best use of our network, amazingly, all of the tools that you see here are online and are free to deploy. We, as just a founding idea, make sure that everything is there and available uh, for those who are looking to do a deeper dive and be connected to the network, or be considered to have kind of a conversation around becoming a site. Please do reach out, and that's a conversation I'd be happy to have with anyone.
Great, wonderful. We'll send a link out to that with the follow-up information from today's session too.
And Sarah, I should also mention, up on our site are snapshots for each of the BCR sites. And so there's more information about sort of who the partners are there if folks are interested in checking that out.
Wonderful. Great. Another question from a few folks is around what success looks like, knowing that these initiatives may be a bit different community by community. And what timeline do you anticipate looking at around outcomes, and how will your evaluation enable you to determine if you've been successful?
So so just and I can speak to this kind of on the policy front. So each of the sites has a policy agenda. So on that front, success is sort of passage and implementation of those policies. On the kind of a larger front, we often get the question of sort of how do you measure equity and what does equity look like? And we usually say that you measure equity all the time because you're measuring inequity. And so we can certainly look to those those measurements as indicators of success on the equity side. And Harrison, I don't know if there's anything else you want to add.
I think that's a good answer, and I think it pertains to both sides of the work. And I apologize, I actually have to step off now, but I can leave you with my colleagues, and you're in good hands. I really appreciated being with you today, and please do reach out if you have any questions or think that our organization can be of assistance.
Great. Thank you, Harrison. And we are at time. I know we didn't get to all the questions, but thank you to Harrison and Jeff and Daniel for being willing to field other questions offline. We'll make sure that you have the information for their group so that you can contact them. And thank you all for attending today. And please join us for future sessions here, and let's keep the conversation going. Thanks again, everyone who presented today. Have a great day.
Thanks.